So as you just saw, and of course you understand, by putting all these different technique of training together, by understanding what could be the best pathway, how to optimize the training pathway, we will most likely increase not only the speed, but maybe also a lot the quality of training. And the other problem, it's not a problem, but by optimizing this training, we also should be able to assess the quality and assess the skill of our trainees, compare the skill between each other, not only for trainees, but eventually for already consultants. And the more funny thing, it can also be a way for one-day insurance, for example, to access your surgical skill, to compare your surgical skill to the other, and indirectly give you privilege or not to do, complex surgery. And I just said to you, today when we want to assess what someone is doing on a simulator, on an artificial bone, or even on cadaveric bone, we ask someone who believes he's an expert, to do a subjective assessment. That's always a bit tricky, because the way I assess it might not be the way Rob is going to assess it, for example. So we have to try to remove this subjectivity and, and try to be more objective. And unfortunately, to be objective, we need to involve the machine, we need to involve the computer. In our small niche, which is otology, of course, temporal bone dissection, it's an easy way to do that, because nowadays, yes, we can use virtual reality, we can use artificial bone, and we have the opportunity to use cadaveric bone. So it's a very fantastic opportunity to develop all this training pathway and this assessment system. So as you know, there is validated scale to assess, the quality of a temporal bone dissection, and they are used all around the world, and we have compared, we have validated those different scales, but there is existing stuff which help us to speak about kind of the same thing. You just saw the slide, so I'm of course not going to go through it again, but I'm going to move to the next one, which is basically what we call the Melbourne mastoidectomy assessment scale. And the reason why we modified this scale a little bit from the original previous validated scale, you can find in the literature, is just to make sure that this scoring system fit better what we want to do, which was the automated assessment of the scoring. And when you go a bit through the description of it, and you see, we go through all the standard stuff. That's a bone I dissected. I'm not saying it's perfect, but I did my best, and I will say it's my gold standard. And I just go a little bit through what we are expecting from, any trainees to do. And of course, you see the dura exposure here. I'm expecting that, it's well exposed from the cortical mastoid. I'm expecting also that they try, to go anterior, around the external here canal. Same thing with the sigmoid sinus. You see, I want to be sure to see all the profiles of the sigmoid sinus, and also, that there is no direct trauma on the soft tissue of the sigmoid sinus. Exposure of the incus, I'm expecting them to expose the incus body and the short process of the incus. Of course, the lateral semicircular canal, and you see the facial nerve here, from the second genu to the mastoid tip, and no need in this scale, but you have the chorda, which is just around there. And I'm going to basically go through all the items and score them and say if I believe it's good or not. So of course, it's extremely subjective, and just to give you an example, when I do 30 assessments in a row, I start to be very efficient. But when I do it again 3 or 4 weeks after, I forgot a little bit what are my standard. And that's a problem, because of course that's very subjective. So this is what I receive. So we ask, beginners to drill, trainees, so supposed to have already expertise in drilling, and of course what we call experts, which are otologists from our team. And I receive a movie like this, which is quite well done. They move the bone in all the different directions. You can see the facial nerve there. You found out where the sigmoid sinus here, but it's not well exposed. Dura is not sure. I don't really sure, but you know, the concept at least of the triangle is respected. There is a bit of dura visible there, so I believe he saw where the dura was, and you see the facial nerve. Then I can see the soft tissue, and I can see if anything has been, you know, destroyed or touched. Facial nerve, dura here, and sigmoid sinus, and the lateral canal and the ossicle. And then I go through the scoring system, and I score them between 0 to 20. So the way we try to automatize this assessment, we took 91 mastoidectomy, and what we did, we divide them in two groups. So 80% of the mastoidectomy were used to develop the system, to develop the model, and 20 were used to validate it. What we do, we have assigned some, you know, specific metrics for each item. So, for example, antrum opening or the dissection of the antrum or the opening of the antrum, you know, we say, okay, this is what we are looking for. That will be the setup metrics of what the computer needs to recognize. And of course, with a bit of time and experience and the outcome we had, we could adjust and align a little bit better what we were looking for. And then the second thing was, you know, I'm assigning a score, which is either 0 or 1, so that's quite basic. But we had to basically find a transition. So when the computer was doing it, where was the moment the computer was moving from a bad dissection, 0, to a good dissection? And we did that for all the different items. We checked all the different item performance. And also we at the end took the total score and we checked if the total score I was giving was, of course, very close from what the computer was giving as a result. So you see, for example, here, that's the dissection of the middle fossa plate, you know, and we expect that it's flat, it's well exposed, that you can see the dura, and we will defining a zone, a volume of bone, you know, the student was obliged to drill to basically get a score 1. Okay, so that's region-wise, that's volume, pixel-wise, voxels-wise, based on. The other thing, as I said to you, we were of course checking that there was no damage on, you know, noble structure, and that's again the same thing, you know, we were checking how many voxels from this important structure have been drilled, have disappeared, kind of. And when that was done, we put, you know, the expert score on the side, which is 0 and 1, and then we put the simulator matrix here, so how much percentage have been done, and that's analyzed by the computer. We fit the sigmoid, and we, of course, try to define the threshold line, which is the moment where the computer moved from not good, 0, to a good dissection. When that was done, we of course checked the accuracy of what we were doing, and you can see that the sensitivity and specificity became quite good. At the end of the story, you see that when I do the assessment and the computer do the assessment, there is in general a mean error of 1.55 points out of 20, which is still a little bit too much, but it's not bad since it's only 7% of mistake. But again, by working in details, we should easily be able to bring that to below 1 point of difference between me and the computer. So the future work is, of course, to apply this system to different bone, so different difficulties of dissection, to continue to apply this system of scoring to more extended dissection, so posterior tympanoid, translap, you know, everything you can imagine in the temporal bone. And that will help us again to structure better the training pathway, you know, and see a little bit like, okay, you have to score on the easy bone a certain level to be able to have, for example, to move to a more difficult one. Bit more funny part, and it's just follow the exact same concept, is basically to not only use virtual reality, because there is some limitation, you know, it's quite fun at the beginning, but it gets quite quickly boring, especially when you get an expert. So we need to be a bit smarter and of course excite a little bit more, you know, trainees and people who are involved in this training. And this is a good example. So you saw the beautiful artificial bone from Phanom, you know, Melville presented. This bone is coming from South Australia. You see a little bit what it looks like. It looks pretty much real, you know, this fake skin. And then this is the bone. It can be used as a cassette, you know, you integrate in a support. You see here a simple canal wall hub dissection. And you see here I remove, you know, the external bony wall, and you see you have this kind of skin, you have the tympanic membrane, it looks very real. Again, you can open the cochlea, you can insert an electrode, and it's already getting there. And I think, you know, the feedback we had, and subjective feedback, because we asked the students, they really enjoy it. And as again, one good thing, it helped them to, you know, when you have a group of different dissectors, one is very good, one is not as good. And they were helping each other, but at least they could compare what they were doing, since they were doing the same thing. And for me, it was very fun, because I organized a prize, the best dissection prize, but the prize was based on the same bone. So that was not, I was not giving the prize to my best friend. I had to be objective, or a bit more objective on what we were doing. And the cool stuff, look, you can also integrate some disease. This is a epitympanic retraction pocket, and you have the cholestealectomy there. You don't see it, but there was some granulation tissue in the mastoid. There is a bit of dura, which is, you know, eroded. So it's quite fun, and you can be extremely creative, and again, you can make it more and more complex based on the skill of the people you are training. And also, and I think that's what I'm dreaming of, it's, you know, you can take this artificial bone in your kitchen, you dissect it, and then you will send me what you have done. The computer is going to score you and give you some comments, but also some feedback again. And I will, you know, ask you to do another bone, the same bone, to modify things, so we can really build again an entire pathway of training. And the idea is the next one. So you take the bone, and this is basically the same bone we were using for the virtual simulator. You print an artificial model, you ask the student to dissect the model, and then using his phone, 3D scan on his phone, he's going to take a picture. And I think if I click one more, that should be moving. So he takes a picture with his mobile, send the file to us, and the computer is going to assess, you know, the quality of what he does, but also we can give feedback and telling me, okay, that's well done, or you have to do this on top of everything, and this is my score. And the funny things, and that's, you know, again, a bit further vision, that could be applied eventually either on cadaveric bone, because you might be you are able to scan cadaveric bone, but it can also be applied to real surgery. So you can basically do the same thing. Imagine you are dealing with a complex pathology, and there is a moment where you are not sure, you have drilled everything you need to access a complicated, you know, lesion in the temporal bone. You can take your picture, you ask someone to take your mobile phone, take a 3D picture, you scan it, you send it, and I tell you now, you know, under the facial nerve, you should dig bigger, you should expose better the jugular gulf, for example, to make sure you optimize your approach to dissect your lesion. So that's all I have to say, but you see there is a lot of things, and that's where we are working on now. That's the next step. We have started to work on this, so I hope soon we will be able to use that as a day-to-day tool.